Welcome to our comprehensive guide on the anatomy and mobilization techniques of the knee and ankle joints. In this video, we'll explore the structure, function, and clinical techniques used to assess and improve joint mobility. Whether you're a student, therapist, or simply curious about how these essential joints work, this journey will provide you with valuable insights. We'll begin by understanding the basic positions and fixations required for effective joint mobilization, then move through detailed anatomical features, and finally, practical demonstrations of key techniques. Let's get started by setting the foundation for joint health and movement. Proper patient positioning is crucial for successful joint mobilization. For knee techniques, the patient is often placed in a supine or sitting position, ensuring the pelvis is stabilized by the position itself. The therapist stands near the patient's lower extremity, using both hands to grasp and support the upper thigh or tibia as needed. Fixation is sometimes aided by an assistant or by the patient's own body weight, depending on the specific maneuver. These foundational steps help prevent unwanted movement and ensure safety during mobilization, setting the stage for effective therapy. The knee joint is a complex synovial, condylar joint formed by the lower end of the femur and the upper end of the tibia. The femur's convex surface articulates with the concave tibia, supported by various ligaments and menisci. Key ligaments include the medial and lateral collateral ligaments, arcuate ligament, ligamentum patelli, and the anterior and posterior cruciate ligaments. The menisci, medial, and lateral act as shock absorbers and stabilize the joint. Understanding these structures is essential for both diagnosis and effective mobilization. The knee joint allows for several important movements. Flexion is primarily performed by the hamstrings, while extension is driven by the quadriceps. Medial rotation is facilitated by the semimembranosus, and lateral rotation by the biceps femoris. These movements are not only vital for daily activities like walking and running, but are also key considerations during rehabilitation and mobilization. Understanding which muscles contribute to each movement helps therapists target specific areas for strengthening or stretching. Arthrokinematics describes the small, passive movements within the joint during active motion. For the knee, flexion involves dorsal gliding, while extension is associated with ventral gliding. Medial and lateral rotations also correspond to specific gliding patterns. The normal range of motion for knee flexion is 135 do 4 to 150 do 4. Extension reaches 0 do 4, medial rotation is about 15 do 4, and lateral rotation up to 45 do 4. Knowing these values helps in assessing joint health and planning effective interventions. The tibiofibular joint consists of three parts: superior, middle, and inferior. The superior tibiofibular joint is synovial and plane in variety, allowing gliding movements. The middle and inferior joints are fibrous syndesmoses, providing stability. The superior joint is formed by the lateral condyle of the tibia and the head of the fibula, while the inferior joint involves the lower ends of both bones. Ligaments such as the anterior and posterior tibiofibular ligaments, interosseous ligament, and inferior transverse ligament provide additional support. Movements at the tibiofibular joints are subtle but essential. The superior joint allows gliding up and down, assisting knee flexion and extension. The inferior joint's gliding supports ankle dorsiflexion and plantar flexion. Proper positioning, such as neutral ankle or slight flexion and inversion, is important for accurate assessment and mobilization. Understanding these small but significant movements helps in addressing joint restrictions and improving overall lower limb function. Distraction of the tibiofemoral joint is a key mobilization technique aimed at increasing joint play, range of motion, and reducing pain. The patient sits at the edge of a bed or stool, with the therapist supporting the leg and grasping the upper tibia. By gently pulling the tibia downward, the therapist creates space within the joint, facilitating improved movement and comfort. This technique is especially useful in cases of stiffness or after injury. Dorsal gliding is performed to increase knee flexion and joint play. The patient sits with the leg hanging, and the therapist applies a dorsal force to the tibia. Progression involves increasing knee flexion and using both hands for greater control. Ventral gliding, on the other hand, is used to improve knee extension. The patient lies prone or sits with legs hanging, and the therapist applies a ventral force to the tibia. Both techniques are essential for restoring normal knee mechanics. Mobilizing the patellofemoral joint involves cranial, caudal, medial, and lateral gliding of the patella. These techniques help increase joint play and improve knee flexion or extension range of motion. The patient lies supine, and the therapist uses their hands to gently glide the patella in the desired direction. Proper hand placement and controlled force are key to effective mobilization and patient comfort. Mobilization of the upper tibiofibular joint includes dorsal and ventral gliding of the fibula head, performed with the patient in supine, prone, or side-lying positions. For the lower tibiofibular joint, distraction, dorsal, ventral, caudal, and cranial gliding techniques are used. These maneuvers help increase joint play, support ankle movements, and reduce pain. Each technique requires precise hand placement and stabilization to ensure safety and effectiveness. The ankle joint is a synovial hinge joint formed by the distal tibia and fibula, articulating with the talus. The proximal articular surfaces include the concave tibia and flat malleoli, while the distal surface is the convex trochlea of the talus. Stability is provided by strong medial and lateral ligaments. Understanding the detailed anatomy and ligamentous support is essential for safe and effective mobilization, as well as for diagnosing common ankle injuries. In summary, mastering the anatomy and mobilization techniques of the knee and ankle joints is vital for clinicians and therapists. These skills help restore movement, reduce pain, and improve quality of life for patients with joint dysfunction. Always ensure proper positioning, stabilization, and technique for safe and effective outcomes. Continue practicing and deepening your understanding to provide the best care possible. Thank you for joining us on this educational journey. Stay tuned for more in-depth guides on joint health and rehabilitation.